Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto. I'm the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Before I introduce my guest, I would like to shout out to some of our overseas listeners. In Germany, Wie geht's? In Brazil, Buen dia. In Sweden, Ein bra dag. In Poland, Zendobi. And in Russia, Dobren den. I hope I didn't butcher your good day. Today I have with us today Mark Thompson, who is our Executive Director of the Medical Society of Delaware. We're going to discuss many issues that we've talked about in our previous podcasts, but maybe elaborate a bit more on them. And I would like to introduce Mark Thompson now. Mark.
Hey, Dr. Biasotto. How are you, sir?
I'm good.
Good. Thanks for having me today. I appreciate it.
No problem.
And hopefully with your international greetings, you didn't create an international incident with some of the language.
I hope so, too.
But I'm impressed.
I hope so, too. I hope we don't have an international problem, but go ahead.
So, no, thanks for having me today. So, I know there are a couple of items you want to go over, but actually, if I may, I'm going to kind of turn the tables here for a second and ask you a couple questions.
Shoot.
We've been doing the podcast now. I believe we're around 20 in and 10 months in. And so just kind of from your standpoint, how do you think things are going and what's your take on them so far?
I believe these podcasts are really relevant to today's activities between the physicians and patients and government in this country. Many of the podcasts, my favorite one is Medical Aid in Dying, in which we talked about the doctor-assisted suicide or dying with dignity or whatever you want to call it. I think there was an excellent point-counterpoint done during that episode in which I learned a lot. Going into this, I had a feeling that maybe I'm not for the process, but coming out of that interview, I said I can at least understand both sides and feel that if I'm requested by my patient, because patients are autonomous, that they would like to move in that direction, I know I would probably make a referral in that regard. That was one of my favorites, but all the other ones have been just successful and very good. And we were getting a lot of support and a lot of listeners, and I hope they all continue to do so, because I have many different topics lined up in the future, which I think will appeal to many of our patients as well as the physicians in the state of Delaware.
No, that sounds great. No, because I'm curious about what kind of feedback you're getting from either your physician colleagues or your patients or other folks out there.
The ones that have listened and the ones that have asked, how do you feel? Things all right? The only bad thing I've heard was from my wife, who told me, I think you talk too much. And I said, okay, I'll see what I can do about that. So I'm reducing my discussions or interruptions so that the speakers that I have can voice their opinion. But I appreciate my wife's input. But on a whole, most patients that have listened and most doctors that have listened have said they think it's a very good program. It's both educational, informative, and up to date. So I'm pleased with it. I'm enjoying it. I have many lined up in the future, and I hope it continues to be a success.
Oh, that's great. I thought you were going to say your favorite one so far was your initial interview with me several months ago.
But that was wonderful, too.
I thought that was going to be your favorite.
That was wonderful, too.
In all seriousness, I have to agree with you. I think you cover so many important topics, and you've got some phenomenal guests who are very well informed, very well educated. I mean, they are clearly experts in their field. So regardless of what the topic is, but I have to agree with you from the executive director's standpoint, the one on the medical aid dying was incredibly informative. But where, from my standpoint, the number of years I've been with the Medical Society, it also, to me, it shows the character and the intent, or let me start that over. So it shows the character of the Medical Society and our members and everything that is right about the Medical Society, because I think one of the hallmarks of our medical society is that of physicians who can come together. They may have differing ideas, but they can have a well-informed, educated discussion and dialogue and bring forth legitimate facts. And that's exactly what happened, I think, in that particular podcast. And at the end of the day, I think that's what helps the medical society formulate even stronger positions, policies, and whether it's for the community, whether it's before the General Assembly, or even within the House of Medicine. So I agree with you. I think that one was one that stands out for me.
Another one was, it takes a village, in which we had an expert come in and talk about what you do with that parent that's unable to care for herself, her partner has passed, and the family is burdened by all the processes they have to go through to help mom out or dad. Yep. And I think that Franca De Marinis was excellent in giving information to the public on how what benefits may be available to them and how they access those benefits, so that they maybe can get some help for mom and take some of the burden off themselves. Yep. And there's also those that may have to go in assisted living or in nursing homes, etc. So that was a good one to me. I really enjoyed that, and I learned a ton of information from them. And I hope that's available. And those two are, I guess, my favorites, even though I had some very important and interesting ones all along. We've done 20, of you know, and most of the individuals that were being interviewed left saying how it was very easy and very fun to do. That's what I want to do. I want to make this a conversation on every issue so that we can put out some data that people or doctors need to know.
Yep. No, I think I know you were a long-time advocate with the Medical Society and getting the podcast. So it really is thanks to your tenacity that we were able to get this up and running. Right. And it's a great thing from my vantage point. And I hear a lot from folks as well. So whether I post things on social media like LinkedIn, where I continue to try to draw attention and awareness, but also let them know that the Medical Society, yes, we do strong work representing the physicians in the state, but also we're doing things to help educate and improve awareness on really vitally important topics like the ones that you've covered before, and I know ones that you're going to be covering in the future. So kind of looking at that lens or that eye to the future, what are some of the other topics that you'd like to explore and that you kind of plan on having guests in on?
I'm having guests in the near future on medical issues such as a syndrome called POT syndrome. Nothing to do with marijuana. It's a syndrome in medicine that is sometimes overlooked. I'm also going to bring in another guest who's going to speak to regenerative medicine issues, how they're using injectable stem cells, platelets, to improve a patient's quality of life. I want to know what's out there that's real and what is not real, because there's a lot of misconceptions about that. So I'm bringing that person in. I have a lot of other ones regarding issues that will be coming up, but I don't want to give you too much information. I'll just leave you to think about that.
Just kind of leave me hanging.
Yeah, leave you hanging.
Let me make sure I tune in on a regular basis. So that sounds good. So, well, let me ask you, what's on your mind? What would you like to talk about today?
Well, today I'd like to go through some topics with you. You are probably the most informed individual in this society about issues that are relevant to patients as well as doctors. One discussion, let's start, is prior authorizations. As you know, I have been an advocate of the elimination of prior authorizations. Totally eliminate, not tweak, eliminate. Right now, states, and our state in particular, is trying to tweak the process so that it's less cumbersome to the physician and the patients of Delaware. The cost of running a prior authorization from a physician's office point of view is very difficult. My staff hours doing prior authorizations during the week, which is both costly as well as cumbersome. And in my opinion, it drives the cost of care, cost of running a practice, it drives it and makes it very difficult to continue. I feel that this process should be eliminated, not tweaked, but eliminated. I have since 2008, when I was the president of the Medical Society, I asked the insurance industry to please provide us data showing that this process is either saving lives or saving money or both. That was in 2008, and here we are in 2025, and I've yet to get the answer. So this is a process that I'm sure is both financially cumbersome to the insurance industry, but they have a lot of money to waste, I guess, because they have to provide all of this information to us. How do we overcome denial and what that denial means? It takes our office a long time to try and get it through, and once my staff has had no effect in getting these authorizations approved, they give it to me and I talk to a peer, and in 2 minutes after speaking to the peer, the test that I ordered or the imaging that I ordered is approved. So it seems to be just a big waste of time, and it's costing a lot of money that I think we could use elsewhere. Plus, I think that patients are being harmed by this. Many of them who have been on long-term medications, all of a sudden that medication becomes a medicine that is prior auth needed. That confuses them. And what do? In their confusion, they come to us and to the doctors and say, well, what do I do?
Right.
So we have to, again, fight for the patient to get what's needed. And in some cases, I think the delay has been costly and harmful to the patients.
Oh, there's no doubt about it.
Exactly.
I mean, because, so I look at, you deal with it every day from the standpoint of your practice. My perspective I think is one that's rather unique, because having grown up in a healthcare family, father being a physician, mom being a nurse, we had these same conversations about prior auth. A number of years ago, I was around the dinner table, and it was just the challenges that they face just in the practice every day, and just to help patients, and just a bureaucratic nightmare. It still continues today. We had those conversations, like I said, 40 plus years ago. And then you look at it from the standpoint, because I don't know anybody who has personally not been affected by the situation of prior auth as a patient. Mm-hmm. I could tell you stories about my daughters, very young at the time, and who we got caught up in the prior auth process. And my entire professional career has been in healthcare. And if I've got a challenge navigating it on behalf of, at the time, my young children, and where did they end up? They ended up in the emergency department. And what procedure ended up getting done by those in the emergency room was the very same one that their pediatrician wanted to order on an outpatient basis. So that's the point about the expense, because that happens significantly.
Oh, yeah.
The other part of where I see it is I hear it every day from folks like yourself and your colleagues as we try to come up with a legislative approach in Delaware. And I know the AMA is working hard on this also, try to get something happen at the federal level. But it's got to change. It is not improving cost of care. All it is trying to attempt to manage utilization inappropriately.
And control.
And hope that patients ultimately give up.
We're doctors.
The other thing is, in a state like Delaware, and Delaware is not alone to this, but when you have physician shortages, and like we have here, and it's documented, the number of hours and upwards of actually 2 days a week that you and your staff have to spend fighting and trying to get a peer on the phone only to get something authorized is time away from patient care. You could be seeing and treating more patients. In a state where there's a physician shortage, that just doesn't make any sense. So now you have backlogs of people who can't get in, can't see people. Where do they go? Many times they end up in a walk-in or an emergency room. That is not the way care should be delivered in America today.
Agreed.
So, it's incredibly problematic. So, it's something that, well, again, not a physician, it's something that we fight on your behalf every day. And, I'm optimistic that we are going to get a bill through this year in the General Assembly. Will it be absolutely perfect? No, probably not. No good legislation is. But will it be an improvement? Absolutely. And, in fairness, we've worked hard with the other stakeholders on this. I would call it a collaborative effort, out there with others to try to get something done. So, I think if we're going to get something, it's this year, and I feel optimistic about that.
I hope so, but still, it's a tweak. In other words, they're trying to make it less burdensome. I mean, maybe it will, maybe it won't, but I still think, in essence, the insurance companies want major control over what happens in your office and between the privacy of your patient and yourself.
Yep.
And that's what they want. There's nothing to prove to me that this is a beneficial program and therefore should be eliminated. I know we're in Dover, they're trying to tweak the prior authorization system to make it less burdensome. But basically, they really have control over just Medicaid and state employees, because they're the only insurance companies that they can do. And even the insurance commissioner says he has no effects or no power over the other insurance companies other than within the state itself.
Right.
That's another problem. So we'll tweak it for Medicaid. We may tweak it for state employees, but we still need to get rid of it. Bottom line, I don't like it. I think it's burdensome. I think it's hurting patients, and it's quite expensive for doctors.
Well, to your point about it actually, not being in the best interest of patients, that's actually been proven out. There was actually a wrongful death lawsuit filed by a surviving, the husband of a person that unfortunately died, and it was tied to delay in care because of prior
authorization.
And it was in 2019. I believe it was Aetna that lost the case to the tune of about $25 million. That's what things have got to change in that regard. So
I agree with you 100%. Now, I have another topic I'd like to move into next, and that's our primary care initiative that's going on in Dover.
Right.
This program has been headed by Dr. Gill in our society to improve, and this has been 5 or 6 years he's been working on this, improve.
And now Dr. Hondashane.
Right, and Dr. Hondashane.
And Mike Bradley.
And Mike Bradley, yes, another. We're fighting to get recognition for primary care. And I thank them for their efforts in trying to get doctors compensated properly for the work that they do. Why is this so important? If you look around the country, trying to find a primary care physician is very difficult. If you happen to be lucky enough to get one, it may take months before you can get to see him just for a checkup. And if you're sick, forget it. You won't have to go to the emergency room. Again, driving up the cost. So what happens? I talk to many medical students. I have them in my office. I train them. And most of them coming out, I ask them, what are you going to do when you're done your medical school and you're going to go for your residency? 10%, if that, say they'll do primary care. And the others say, well, why should I do primary care? Because I'm coming out of medical school with $250,000 to $300,000 in debt for my training. And then, at the rate you're reimbursed, Doc, primary care doesn't look too attractive because I'll be paying this off into my 60s.
Right.
And so I say, that's not right. So I feel the primary care is the foundation of medicine. And if the foundation of medicine is weakened, if it's cracked, the house falls down. And this is what is happening. So to substitute for primary care, we're allowing nurse practitioners in some states to come out of their training and put up a shingle. Now in Delaware we have some restrictions. When they come out of their training, they have to put 400 hours in beyond their training under a doctor who has to approve them in the end. And they have to take the same test that we do for our certifications, etc. But when you look at the training that goes to the nurse practitioners versus physicians, we have 5 times more hours in training before we can hang a shingle. So, who do you want to go to? Now, the majority of nurse practitioners who I also teach, coming out of University of Wilmington, say they don't want to go out and hang a shingle. They want to work under a doctor. And I think that's a great plan because they can see patients. If they run into a jam, they can give me a call or the doctor that's taking care of that's the head of the office and ask questions of him or her and get the answers and move on in the right direction at that point. So what are we going to do with this primary care initiative? And have they gotten to resolve this issue after 6 years of trying? I'm not so sure. So what do you think on this issue?
Yeah, no, there's definitely a lot. There's a lot to unpack in what you just addressed.
Uh-huh.
Yes, that while you talk about the scope of practice topic, but Delaware has already passed some laws that, and again, this goes back to the concern about access to care and the shortages of physicians, and now actually shortage of all healthcare workers in the state, including nurses in various specialties. But I know we've always taken the tack that we value the nurses, the PAs, the techs.
We certainly do. There's no problem there.
Because everyone is a vital member of
and has
the
a
team,
place, yes.
a vital member of the team. So, but that, like you said, Delaware's not the only one, but a number of other states having passed laws around that scope of practice. But, I think, we were able to get some initial primary care legislation passed. Had to do with, again, looking at helping with compensation, particularly for those who are in independent practice, but actually all primary care, because you all are those like yourself who are in independent practice. You have to be able to keep the lights on. You have to be able to fund the staff. You have to be able to be there for your patients. And really, this all boils down to providing access to care for people in the right setting, at the right cost, at the right time. And it's all that's a critical element, and we're losing sight of that. And I know the industry is looking at trying to do things around value-based contracts and accountable care organizations, and there's some merit there in improving certain things in contracts and making sure that everyone does meet quality measures and metrics. But it gets tougher and tougher because you have more and more hurdles to jump through. There's diminishing marginal returns with everything in life, right? So as long as that what that bar is every year, then great. But if that bar keeps shifting on you, then that's where it can be a challenge.
Well, you mentioned keeping the lights on and keeping the staff happy, and that means the cost. All of those costs increase almost yearly, when every year we're faced with a reduction in pay to all physicians in general.
Right.
But primary care can't afford. Every year it's a 2.8 to 2.6 reduction from CMS. And,
Right.
Medicare, then its costs go, the reimbursements go down. Other insurers follow whatever Medicare offers.
They're tied to those contracts.
They're tied to the contract.
They're all tied to that, a percentage of Medicare.
Exactly. So it just gets worse and worse. We are getting less reimbursement, and the cost of keeping an office is going up. Now, you may say, well, a lot of doctors are now swamping the hospitals and want to work for the hospital system. That's going to cost more money for the system. Why? Well, you got a doctor that works for X hospital, okay? They're going to be obliged to do all testing, all imaging, and everything they can do for that patient in the hospital setting. In the hospital setting, the cost of those tests and those imaging processes are sometimes 5 times more than what they can get outpatient-wise in another setting, in an independent group.
Right.
So the cost is just going to drive up. Plus, hospital-based physicians are very frustrated at their hours and things like that, which is going to lead me into another topic. And that itself, doctor-based physicians, is leading me into the next topic, which is doctor unionization, which, as you know, area hospitals are now have physicians who have gathered together and have formed unions, or trying to form unions. By law, they are allowed to because they are employed by a company, and therefore they can unionize if they so wish. Myself, out on the street, and all the other docs that work out of the hospital setting cannot unionize by law. However, I would like to see us be able to collective bargain with the insurance companies. That would be a good thing if we could group together and do so. What do you think about what do you think about unionization in general?
Well, it's interesting. This is a growing topic that my colleagues and I across the country, we talk about. You had mentioned about some of the recent advances in union activity here in Delaware, but it is literally occurring all over the place. And just recently I was in a meeting with the AMA, and just the unionization landscape just for physicians. But within that, there's a couple elements. There's also residents. Residents are considered, but they cannot be part of that employed physician section. So the residents, if they wish to join a union, they have to vote independently of those employed physicians that are in the hospitals.
I did not know that, but that's fine.
So, but what is out there, and this is from the AMA, that there's a group called the Committee of Interns and Residents, and they represent about 20% of all medical residents in the United States, and that's up from 10% in 2019. When we're looking at how it's growing amongst other employed physicians out there, you're talking it's 6.3% of physicians, 7.1% of surgeons were unionized. That's up, and that's in 2023, I believe, and that's up from 5.7% in 2014. There's one study that indicates that there were 77 petitions covering over almost 7,100 employed physicians that was filed in that period of 2023 and 24. So, what does that look like? How and where are those petitions filed for unionization? Again, during that 2023-24 period, union petitions by employed physicians, again, excluding the residents, were filed in a range of employer settings. Of those, 49% were filed against hospitals, 38% against community health centers, and 13% against non-hospital corporate owners, such as Optum and other private equity-based companies. So, what we're seeing here in Delaware is not unique compared to the rest of the country. It is growing exponentially.
I will be having a guest on unionization coming up. One of the physicians who's employed at the hospital is going to come in and discuss what his intentions are with the unionizations. But isn't the end-all, be-all of a union is a strike, i.e., they don't get what they want, and they say, okay, let's get the picket signs. Now, I don't know a doctor who wants to do that because it's just not in our blood to strike. That means we would be abandoning patients and patient care. That's not in our blood. Right. So what is the end-all, be-all when they tell you, oh, yeah, you want that? Well, you're not getting it. So what happens then?
Well, as part of the collective bargaining process, what can happen, both for the, particularly whether it's the residents or the employed physicians, what we're seeing in some of the other benefits other than the initial, like you said, the strike activity is that, particularly when it comes to residents, they've been successful in negotiations around wage increases, health insurance options, retirement contributions, parental leave, and work hours. The employed physicians cite staffing levels as, really primary driver around unionization too. So, what can happen there is that, again, with the collective bargaining, you can also provide some support for the appropriate staffing levels and support around the hospital, in addition to those other things that are broader, workplace environment type of issues. I mean, you're right. It's physicians. Your oath is a little different. Your actions are a little different. There are some things that physicians, again, depending on who they're working with, there are different entities where they can form the union under with the physicians, and so it really is all tied into what's there in their collective bargaining situation with that a particular employer. But it is complex.
I would like to see collective bargaining be allowed throughout the physician community, only to go up against the insurance companies and say, here's what I want.
Yeah.
And if you do not, we will not take you as an insurer here in the state.
Yeah.
I mean, that's a way that we can control it without going on strike. We can have a numerous amount of physicians in a group who can say, this is fair, this is what we want. If you don't give it to us, we're not going to accept your insurance.
Particularly in independent practicing physicians dealing with payers and contracts, there's this little thing called collusion, and you have to be very, very careful, and that's why independent physicians don't band together in the construct that you're talking about. But however, we have here with the Medical Society, we have what's called MedNet. Mm-hmm. And MedNet helps 4 different physician organizations that are independently structured. They are their own legal entity. They can legally get together and have MedNet, which is a separate for-profit company, subsidiary of the Medical Society. It's not the Medical Society, which is key. And that's how physicians who are in independent practice who wish to have the opportunity to negotiate some of those contracts, particularly in primary care, can legally do that. Well, if you came to me and said, Mark, I want the Medical Society to do this and get involved, that gets involved because we're a nonprofit, right? And that's collusion, and there has to be that.
Well, I'm president of Newcastle County's physician organization,
right?
And I'm very happy to be a member of MedNet, as the members in my organization are, because we have negotiated some good terms with some of the insurance companies on many issues.
Right.
And that, I guess, is considered collective bargaining in a way. And it's not collusion. We're just asking for what is fair. That's all. So the AMA's position on unionization is not too much in favor of it, though, correct?
It's interesting. It's the AMA actually had a resolution passed not too terribly long ago, and it's very similar to what we did here in Delaware. And it actually does support the physician's right to engage in collective bargaining. So it's interesting you ask about the AMA's perspective on physicians and unions. So the AMA actually did pass a resolution, and very similar to what Medical Society of Delaware did, which actually, so the AMA's official position is that they actually support the right of physicians to engage in collective bargaining.
So again, they see the problems that we're going through finally.
They support
your rights. In the past,
they
did not.
Yeah, but they do now support the rights of physicians to engage, explore collective bargaining. Mm-hmm. So that the AMA's position has evolved over the.
Okay. Well, I hope we move in a direction that everybody's happy, and we know that strikes will never occur because physicians, it is not in their blood to do so. We're altruistic individuals, and that's how we look at things. Right. But we would like to be treated fairly. All right, I think it's a good time to take a break from this discussion. And before we leave for the break, I'd like Mr. Thompson to give us how you can communicate your concerns, what you think, on issues we've just discussed. We would appreciate it because I think we can learn a lot from people and physicians out there listening about topics we've just talked about. So take it away, Mark.
Yep, so no, be happy to. And one of the things, too, I want to make sure that I get across both to you and everyone listening is the issues that we brought up so far, and I have a feeling you're going to get into after the break, are not always so simple and clear-cut. And hence in the time that we have, I'm just speaking to things at a very high level. And so, but that actually is if our listeners do want to provide comments, feedback, suggestion for future topics, we'd love to hear from them, and we'd love to do so via email. And the email is healthcare.reality@medsocdel.org. Again, that's healthcare, one word, .reality@medsocdel.org. Because we'd love that feedback.
Sure would. That would give us something to chew on and think about as we go on with these podcasts. Okay, so let's take that break.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Hi, it's Dr. Nick Biasotto back from the break with a general discussion with my guest, Mr. Mark Thompson, our Executive Director of the Medical Society. One subject that I'd like to discuss is the cost of care in the United States, and yet with the cost and what we spend, our outcomes are poor. The United States, as is well known, has some of the best medical facilities in the world, the best doctors in the world, the best medical schools in the world where doctors get superior training, and the best research centers in the world. We spend a lot of money to get that to work and hopefully get some benefits out of it. However, the cost is becoming almost unsustainable. So, as I call it, the medical system in the United States is broken. And there's many reasons why that is. And in my future editorials, I'm doing a part 2 in the near future regarding how hospitals make their money, and then part 3, how insurance companies make their money. I've also talked about already in part 1, which we haven't released yet, is how doctors are making it out there. But if we look at the cost of care as it increases and increases and increases, we have to sit back and wonder why. Well, I have an opinion that the reason being is that the majority of Americans are overindulgent. I think we spend too much time drinking, too much time eating, too much time smoking, too much time doing drugs, and little time doing exercise. I feel that if we want to put our money where our mouth is to improve this situation, we should have programs to do so. Educational programs to show people how to eat properly. Educational programs to show them how to slow down on the alcohol and the smoking. This is something I think we need to do, and hopefully we will see these things happen in the near future. Movements are in progress to see that we learn what would be good nutrition for ourselves in our society. And I think the studies have shown that the generation below me, and I'm the baby boomer, will have a shorter life expectancy than we do. This talks a lot to that. And when you look around in other countries, you see that the biggest problem in America is obesity because of our overindulgence. And if you look at other countries, a lot of them do things totally different. And their outcomes health-wise are better than ours. I believe we're either 38 or 40 in the developed country for outcomes. That's not good, considering all the benefits medicine offers in this country. How do you feel about that, Mark? You got any comments?
Yeah, I mean, short answer is yes.
Okay.
I mean, it's an incredibly complex subject, and you touched on so many of the contributing factors, but the reality is our healthcare system, at time was greatest in the world, but now it's gotten more complex and more costly, and the outcomes aren't there anymore. Mm-hmm. And so something's got to change. The other thing is, as the outcomes have changed, and unfortunately not for the better, costs, as you said, continue to go up. And, what's one of the leading causes of personal bankruptcy these days? Or medical bills. Mm-hmm. And, why is that? When our insurance plans, have shifted now to the basic deductibles, or what once used to be considered catastrophic plans, $7,500, $9,500, $12,000 for a deductible. Now you're hoping that nothing happens, and you're just doing some basic preventive maintenance things. But when something happens, and it will, Americans are left with these massive bills, and what happens there? The hospitals and health systems have complex finance and economic systems. So do the payers, and so do those in independent practice. But then also, where the rubber meets the road is with the patient. Mm. And unfortunately, the patient many times will get caught in the middle of all this. And so it has gotten incredibly complex. If anybody says they have the answer,
God bless him.
God bless him, and I wouldn't buy a bridge from him. I would continue to move on. It's just gotten to the point where the system has gotten very, very complex, and some people look at is a single payer an alternative?
I was just going to bring that up.
I don't know. I don't know what the right answer is. I can talk about things like here in Delaware. Currently, what are some of the things that make, Delaware costly or unfavorable, at least from the standpoint of physicians? And Wallet Hub has done studies where Delaware is one of the least favorable states for a physician to practice in the nation.
Mm-hmm.
Why is that? Part of it is lack of payer competition is a big thing. A lot of that does drive costs, for the patients and the ability to negotiate contracts. There's a lot of other regulatory items here in the state that are not very favorable for physicians either. And one of the things and I feel like at times I'm on a one-person crusade with this, but I wish
maybe two-person.
Yeah, maybe two. But it's really, Delaware does really have strong, respectable health systems and outstanding physicians. Yes, it's also true that we have a very unhealthy population in our state, but I just wish the state as a whole would look to healthcare, particularly medicine, as an opportunity for an economic driver or an economic engine to help within our state. The studies are there to show the jobs that healthcare creates, particularly physicians in your practices. I just wish we would change the paradigm and focus rather than looking to regulate physicians and the practice of medicine to that of how do we make it better for physicians? Mm-hmm. How do we deal with our growing population here in the state, particularly an aging population? How do we retain the physicians that we have and broader workforce? And also, how do we figure out ways to be creative when it comes to recruiting physicians in the state? Is that through certain, tax advantages and subsidies? Housing in this state. One of the things that also is a challenge here in Delaware, and which also is affecting the access or the supply of physicians, nurses, PAs, and others, there is no one silver bullet or one single item that drives all these issues. In Delaware, we've got challenges within our education system. And some folks will say, well, why is that an issue? Well, Delaware spends per capita, I think, 7th in the nation in total spending, but our outcomes in education is 46th in the nation. Okay, why is that relevant? Well, when you have a young family and they're looking to come to Delaware, the physician may say, I love the clinical enterprise, I love the community, I like the medical community. The next question is, what are the school systems like?
Exactly. Mm-hmm.
That becomes really hard to attract that physician.
Well, we could get into the subject of school choice too, which is
which I can't even go
the
there.
Spectrum of this.
But the other thing is, when you're looking at these things, again, is what's another issue is affordable housing. Mm-hmm. Affordable housing in Delaware is becoming more. It's a problem nationally, but it's also a problem in Delaware. So when you have a young physician who's coming out of school and their residence in their landing here, they're $250,000 to $300,000 in debt.
Right.
And you're seeing more and more physicians who are married to physicians. So if both are in debt,
it's to pay it.
Yeah, it's so you start to look at all of these issues, and it becomes a challenge. It becomes a challenge to improve accessibility, to improve affordability. So what ends up happening? Yes, if the hospital or health system is going to employ folks, the salaries have got to be there to be able to match so that they can have, be able to afford the housing. And we're not talking about anything fancy, but, we're just talking about the basics here. So, all of this stuff goes, back hand in glove. The other thing is, you had talked about what CMS has done at the federal level with reducing physician reimbursement. Mm-hmm. That also does not factor in inflation. And during the pandemic, we were running at 8-9% inflation. Mm-hmm. So not only did you have a reduction in that compensation piece, but you also had an additional reduction, almost like a hidden tax because of cost of inflation. And I will say the AMA is fighting, and they're very focused on the compensation piece, with getting that fixed with CMS, but also through looking at other pieces of legislation that does provide for adjustments in inflation too. So, going back to the original topic, I know I'm kind of taking a roundabout or a circuitous approach, but the costs have gotten out of control. The availability and accessibility is not improving. Physicians the average age of the physician is up there. The backfill, you just don't grow physicians on trees. You're talking 4 years undergrad, 4 years medical school, then depending on your specialty, the number of years in residencies and fellowships. And then let's factor in the number of limited graduate medical slots, for residency and training. Delaware, fortunately, is growing in that capacity with what's happening with some new residency programs. But we just still don't have enough physicians to meet the demand for care, whether it's here or nationally.
Well, believe it or not, this is the time of the year where graduating physicians try to match with a hospital for their residency plan. And I think I've heard this number, I don't know how correct it is, but 850 primary care slots were never filled. So that shows you that how few people are going, and doctors are going into primary care. But, let's look over.
Well, real quick, the other thing is, you look at the rest of the American healthcare system, if you will. You look at, and I'm not prepared to talk about this, but we all know the rising cost of pharmaceuticals. We all know the rising cost of insurance. Those things are very well documented at the national level. And at some point, it's just not sustainable. Something's going to break.
Agreed.
And I hope when it does, it's not a catastrophic type of situation.
Agreed.
But it is not the sustainable model.
Well, if you look overseas at other places, other countries, and how they do it, they look at medical care as a right, not a privilege. Looking at it here, it seems more of a privilege than a right. In other words, you have to be privileged to have the money to get the insurance. You have to be privileged. But I still wrestle with this in my mind, is the way to solve some of the problem is to have a one-party payer system in the country, yet that takes away capitalism. That puts that aside.
Right.
We are a capitalistic society here in America. But a one-party payer system would take away a lot of problems, a lot of redundancies and things like that, if we could ever get to that. And I think that would have many of the insurance lobbyists raise the cane with the government. There's
pros and cons. I know there's debates on both sides of that, but then we talked about all those other costs. How does it really help to rein in those costs? Another one too is just the cost of labor. In practices, and not just the cost, but also the quality of the workforce. I hear from so many physicians, who are in independent practice, but also those who are employed, that it is a challenge to, one, keep really good staff, because what has happened, particularly during the pandemic, was, rates went up. The cost at which they would pay folks went up. So the system started to feed on itself. And by that, what I mean is, so knowing that there was, good quality workforce in the community, so hospitals, health systems, institutions like that could actually pay a higher salary to those techs and those nurses who were there in the community. So then what happens? It just doesn't stop there.
Right.
Neighboring states that are larger, with larger health systems, what do? Their salaries and the rates that they're going to pay people, and they want to attract quality workforce, that goes up. And so then smaller states, how do you retain that qualified workforce, because they're apt to continue to move on, where they can continue to have that additional salary. So it feeds on itself that way, just from a labor standpoint only. So it's complex is an understatement. I don't sound like Captain Obvious,
but it's been made complex by
Yeah.
the constant changes that the government makes and constant changes that
Yeah.
I guess the insurance companies, the hospitals, and all that make. Looking overseas at some of the places there, their medical care is free.
Yeah.
Absolutely free.
And
the government pays.
Well, the other thing is I don't know of another industry like that in healthcare where you're basically regulated on and you're under contract of what you can actually collect and get paid. Your costs to deliver that care for particular procedures, time, are above and beyond, but if you're accepting insurance, you have contractual allowances, what you can actually get reimbursed by that payer for that procedure. Mm-hmm. So whether you're a primary care or a specialist, so you're kind of capped there. Then you also have other state regulatory and federal regulatory requirements that you have to meet. So you get squeezed there. You're not always getting reimbursed on the value of your services and what you're really providing. Mm-hmm. You have cost of materials and supplies, mm-hmm. overhead, electricity, staff, et cetera. And when that doesn't keep up, what do you do and how do you do it? And so you're regulated there. However, you're also regulated on your collections technique. Mm-hmm. So I know so many physicians and who work with patients. And I know hospitals and health systems do too, but the amount that now everyone is owed because of, again, I go back to those very large deductible plans, mm-hmm. that patients just can't afford that. Now, fortunately, there are some good laws out there and good credit collections practices where you can get people set up on payment plans, mm-hmm. and that people very much need, and that's helpful, But again, the way the financing and deliveries is like no other industry in America. So, like I said, I'm talking that at a super high level. But, I think all of these things ultimately begin to, like you said, they drive the cost up. Mm-hmm. You see entities that have to cost shift, to make up for areas that they just are not financially bringing things in. So, yes, you do have to cost shift. But it's tough because you're under contracts and you're told what you can get paid and what you can't get paid. And by the way, you're told what procedures you can and can't get done unless you fight for a prior auth. So we can bring that topic full circle too. Right. So I don't know. Maybe there is something to, what is it? The study that just came out where Finland for the 8th year in a row was identified as the happiest and one of the healthiest countries in the world. So maybe what I need to do is for the Medical Society of Delaware is to explore a sister.
Why don't we go to Finland? Why don't we go to Finland?
I think we need to set up a sister relationship.
There we
with
go.
Finland
I'm up for
and
that.
Figure out. I think we need to do a good case study.
Put me down on that list to go to Finland.
Do a good case study and say, hey, what works?
There you go. Oh well, we talked about a lot of things here today, and I'm sure we could talk for hours on many of these subjects. I hope somewhere along the line, one of our government or our administrations do something to make medicine better in this country, to make it a business. Now, I think the present administration is more business oriented, seeing that our country becomes more business oriented. Well, let's take this business and fix it, right?
Yep. And however, the other thing too is how to restore back to physicians and nurses and others. How do we eliminate that burnout? How do we eliminate the fatigue?
It's tough.
Because it's an amazing profession. Like I said, having grown up in it and worked in it my
entire professional life. Couldn't do anything else, to be honest with you.
But we have to also begin to cherish and get back to how do we take care of physicians, nurses, PAs, and others, and everyone in that whole cycle, that continuum of care. Because right now, whether I talk to, folks who are in the hospital or folks who are in long-term care facilities or other areas in healthcare, I mean, everyone is doing their very, very best. But also at the end of the day, everybody feels like they've gotten beat about the head and neck. And guess what? Then the next day, it's like Groundhog Day all over again. So which kind of leads me to one thing that, what are something that we're trying to do a little differently here in Delaware? So, like I said, some of those other stakeholders and my counterparts here in the state. So, And that includes folks from the Delaware Healthcare Association, the Delaware Nurses Association, of course, us, the Medical Society, the Delaware Association for Home and Community Care, and the Delaware Healthcare Facilities Association. For the first time ever, we've joined forces and banded together to create what is now known as the First State Health Leaders Alliance. And the idea is, we realize we're all in this together. And how can we make a difference? Because, yes, we have our own areas of responsibility. We have certain things, but it's like I tell folks, probably, at the end of the day, we probably agree on 95 to 98% of the issues. Let's, how can we all collaborate on that? And then on that other 2 to 5%, that we don't agree, okay, how do we still professionally agree to disagree, but still advance quality of care in Delaware? So we've actually come up with 8 points, believe it or not, and where we're trying to champion issues around health workforce development, reimbursement issues and rates, prior authorization reform, public health and emergency preparedness, workplace violence, removing healthcare barriers, transitions of care, and affordable housing. And we're doing this, we're just getting started. It just kicked off in around March 20th. And it's just the beginning. But we're trying to do it, again, from a community standpoint, but also with our legislators, our elected officials in Dover, and to show them that, hey, we are locked arm in arm on these 8 issues, and we're trying to do something to improve the quality of life in Delaware. So it's kind of a big deal. It's never happened before.
Okay. Well, I have enjoyed this conversation very much, and I think we'll be signing off shortly on it. I hope everyone else does, and if anyone has any ideas that they want to get forth, bring forth to us so that we can further discuss things that may be pertinent to either patients or physicians in Delaware.
Yeah, or even help us do deeper dives on these things that like I said, that we talked very high level about, because all these things in their own right can really do deserve a deeper dive with true content experts, because that's what it requires. So I'd love to hear from folks who'd be willing to talk about any of the issues that we brought up to come in and be on the podcast with you.
I hope we get some good positive feedback. As I mentioned earlier in an earlier podcast, I am coming out with a 3-part series, which I'm going to release at the same time, all 3 parts on the broken system in the broken medical system in our country. I finished the part involving doctors. I'm right in the middle of how the hospitals make their income, and I will also be doing a 3rd part about how insurers make their income, and see what we can do with that and talk about that and maybe get some feedback. But before I sign off, I would like to thank Mr. Tom Minton, who has been our director and producer on all of our podcasts. We appreciate his insights and his technical knowledge so that we could get these done. Tom, it's been a pleasure working with you so far, and I hope we have many more times that we may work together.
Well, Dr. Biasotto, thanks very much for the kind words, but also for the confidence you put in me when we first met, and it's been a while back. If you can imagine, we've got 20 shows completed already over 10 months, and there was some time beforehand that we all learned a little and shared a lot, and the results are really starting to show something that, quite frankly, I wasn't sure how it was going to turn out. But compassion and commitment are things that really are strong, and if you've got that and you can put that to good work, there isn't anything you can't really do. So I want to thank you guys for your confidence, and also all the folks that are here at the Medical Society of Delaware who are behind the scenes, who make things happen when we need them to happen, and we'd be lost without them, and we salute them. And we also ask our listeners to come share with us, be a part of this. It's only going to grow, and I'm happy and proud and honored to be a part of it, and I thank you every day that we work together for a pretty great opportunity.
Thank you, Tom. Okay, this is Dr. Nick Biasotto signing off. We'll bring you more podcasts in the future. Please stay tuned.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts for any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.